I'm Debbie Sharp. I'm Professor of Primary Healthcare at the University of Bristol. And my main job currently is being head of the School of Clinical Academic Training, which is the joint partnership between the University of Bristol and the Severn Postgraduate Medical Education in Health Education Southwest. The easy answer to that is there is no typical week. So I should say that I don't actually see patients anymore. I stood down as a partner in my practice some years ago in order really to concentrate on the work I'm doing in the Clinical Academic Training School. I also stood down as being head of department, which I had set up in 1994. So most of my week is involved with academic trainees, clinical academic trainees, medical clinical academic trainees, all the way through really from the very beginning of ACF posts, through PhDs, through ACL posts, and on to hopefully people who are in clinician scientist or advanced fellowship posts, looking after all aspects of the academic side of their job, not the clinical side of their job, but the academic side of their training in whatever post they're in. Well, I think what I enjoy most is helping other people achieve their ambitions in their academic life. Helping people perhaps move from an academic foundation post into a clinical fellow post, people getting a PhD fellowship, people getting a really good paper published, people being given, for example, today I heard somebody being given a fellowship at the Royal Society of Medicine in the paediatric section. All those good news stories, which I think comes out of, I hope comes out of being part of our very well balanced and supportive clinical academic training school in Bristol. Well, there are lots of challenges. I mean, most challenges are around people, politics, and money. Actually, money's not such a big issue because most of these posts are well funded, and that's not normally a problem. Money's the problem when people are applying for external funding and it's incredibly competitive. People, everybody wants the same thing. Colleagues can be very difficult in terms of everybody wants a post and there aren't enough posts to go round. And the politics really, I suppose, are around what are we going to focus on? What are our strategies? And everybody thinks that their specialty is as important, if not more important, than another colleague's specialty. And the politics of keeping people from very diverse specialties happy is probably the most challenging part of my job. I think one of the great appeals is that it provides you with what you could call a portfolio career. It provides constant interest, questioning, gives you the opportunity to delve deep into issues that you're really interested in, gives you an opportunity to meet a lot more, perhaps different people than you might do if you were only doing your clinical work, allows you to have some sense of esteem as you start to develop your role in your particular academic niche and people begin to recognize you as an expert in that area. I think it's very flexible. I've always been a great champion for women in medicine, and I think academic medicine is actually a very flexible type of career for women. I often say to them, you know, you can sit and finish off your paper sitting at the desktop or your laptop at home with a couple of toddlers around your feet, breaking digestive biscuits up, messing up the carpet. You simply can't do all that care at home if you're on the front door and doing an A&E job as a full-time doctor. So I think there's a lot of flexibility, as I say, for women in academic medicine. It's competitive. There's a lot of heartache when things don't go right. But most of the people who we attract to our clinical academic training school stay with it. Very, very few people decide not to continue. Early on, it might be that people think you have to be insanely clever And you do have to be clever, but most people who go to medical school are pretty clever. You do have to have a lot of resilience. You do have to be pretty single-minded. I think doing a PhD is one of the hardest things that anybody ever has to do. It's jolly hard work for 3 years. You absolutely have to embed yourself in it. I think that you get quite a lot of, being pushed back. You'll apply for jobs, you'll apply for grants that you don't get. You have to be prepared to take criticism. I think one of the biggest issues can be that your colleagues who are not academics don't quite understand what you're doing and why you're doing it. There's a sort of sense for some people occasionally that, oh, you only work half time. Actually, no, I don't. I just happen to spend the other half of my time in a lab or, doing big data analysis at a computer in a room. And that can be quite difficult to cope with when you're starting off in a clinical academic career. You're not half time. Do a lot of inquiring, do a lot of thinking, don't rush into it. I'm quite concerned that on the whole, people are being asked to make decisions about their specialty rather too early in medicine these days. The way that the internal medicine training is going, people are having to make some quite early decisions. Get lots of advice, talk to all sorts of people. Think outside the box. Don't assume that you have to stay where you trained or where you did foundation or even where you did your early clinical years. If there's somebody who you really want to work with and at the other end of the country, make yourselves known to them, go and talk to them. It may well be that that would be the best place for you to do the sorts of academic work that you want to do. Get lots of advice as to how to fill in the application forms. I mean, not everybody, but a large proportion of people will start on the ladder if they haven't done an academic foundation post for an academic clinical fellow. Think very carefully, work very hard getting the application together. If you got an interview, prepare very thoroughly for that interview. Make it very clear why you want that post in that specialty in that particular location at that particular time. It's not rocket science, but it does require a lot of thought and time and effort to make the applications for these posts and make them successful for you. Well, I think there's various ways of looking at. The first one I want to just go back to is that there has been a sense that with Walport integrated academic training, that unless you got on the ladder at the bottom, and that might have meant intercalation prior to academic foundation and ACF and so on, there was no chance of you getting onto this clinical academic ladder and getting a PhD and so on. I think junior doctors need to realize that it isn't the only way, and we have a lot of people who get a PhD fellowship without having done, for example, an ACF post. So I think we need to make it clear and transparent to people that there are more ways of getting into clinical academic medicine than what looks like the standard ladder approach. So that's one thing I'd want to say. I think probably you're referring more possibly to gender, race, and so on. I think we're all aware that over 50% of medical school applicants are women. The numbers drop off quite remarkably as you go up the academic ladder. And although we have lots and lots of women in ACF posts, PhDs, by the time you get to ACLs and senior lecturer posts and certainly professorial posts, the numbers are declining. And there are all sorts of reasons for that. And it's quite specialty dependent quite often. I think surgery has a very difficult time. I think the BAME issue is very, very complex. I think it depends on where people have trained, what opportunities they've had in their undergraduate career. I do know that in some medical schools and in Bristol at the moment, we're working extremely hard to make sure that there are as few barriers as possible from people from all types of background to get through their medical degree and do whatever they want to do with it once they've graduated. I would say that we probably still in Bristol look rather white and middle class in our clinical academic training school. I don't think we probably quite represent the city as a whole. And we've got a lot more work to do. and it's something that I think possibly we need to do on our website, and make sure that we've got role models and people who are available to talk to about what it would be like to be perhaps somebody from a minority ethnic background in a clinical academic training school where there are rather few people like themselves.